it continues to do well. The second patient here, who had stable disease, had a partial response after further treatment with an increased dose of his T-cell clones. So this one patient that was reported in the New England Journal did very well, and although the clinical response is not representative of the other 3 patients who had partial response to stable disease, the T-cell persistence profile is. We could track these T-cells in vivo. They have clone-specific T-cell receptors. We can use real-time PCR and demonstrate in this case that these T-cell clones survive between 1 and 3% of the total CD4 T-cell count, total peripheral blood mononuclear cell, which is extremely high fraction for it to be occupied by a single T-cell clone for 85 days. Actually, it's going on to 2 years now, and it continues to persist in the peripheral blood. Single infusion, no lymphodepletion, no exogenous cytokines. So these cells will maintain their survival autonomously. And this is a PET scan of this patient. This is his upper body, this is his lower body. There's a lot of non-specific uptake, but the primary lesion is shown here in the lung, and another lesion, and then the metastatic lesion is also shown here in the left inguinal node. This is also non-specific uptake in the bladder. Single infusion and NY-ESO-specific CD4 T-cell clones was given to this patient at a dose of 3.3 billion cells per meter squared. And there's complete resolution of the disease, and he remains disease-free more than 3 years later without further treatment. So the question we asked was, well, NY-ESO-1 is the cancer testis antigen. It's found in melanoma, it's immunogenic. It's also found in various other solid tumors like breast cancer, lung cancer, and colon cancer. However, this heterogeneous expressed. If you section one of these tumors and you stain it with an antibody NY-ESO-1, you see maybe 20–70% staining at the most of melanoma cells. And so if NY-ESO is heterogeneously expressed and T-cell clones specifically target NY-ESO-1, then why do we not see antigen-loss tumor variants develop, as we did when we gave CD8 positive T-cell clones in our earlier studies? And one possibility may be induction of antigen spreading. And what is antigen spreading? If you give NY-ESO specific T-cells and you kill some of the tumor cells that express NY-ESO-1, they release antigens. Not only the NY-ESO protein is picked up, but all the other tumor-associated proteins can be picked up by these autologous dendritic cells, brought back to the draining lymph node, and then you may induce endogenous response, either CD4 and or CD8 T-cell responses to these non-targeted tumor-associated antigens. These T-cells then fly back to the tumor, hopefully, and eradicate tumor. And so perhaps that's what we're seeing. We looked at responses to other tumor-associated antigens, MART1. We saw an induction of MART1, even though we didn't transfer MART1 responses. We saw induction to MAGE, again, even though we didn't transfer MAGE-specific responses were induced in these patients. And of course, NY-ESO responses, as we had expected, because that's what we had transferred in the patient. Finally, we also looked at GP100, another tumor-associated antigen, and this did not increase after transfer of the NY-ESO-specific CD4 T cells, and it turns out the tumor is MART1 positive, MAGE3 positive, NY-ESO positive, GP100 negative, suggesting that this may be antigens that's represented. Now, NY-ESO-1 is potentially an antigen associated with tumor melanomas with high replicator potential. I hesitate to say stem cell-associated antigen, but some people have called it that, so that may be the other reason why targeting only a heterogeneous population of these cells may have resulted in tumor eradication, although that's not been proven either. So the conclusion from this initial study of CD4 T cells is that this is safe. We observe an extended duration of in vivo persistence by giving these cells alone. We may have induced antigen spreading that correlated with clinical responses we saw in 3 other patients, having shown here. There was also increased antigen spreading associated with a partial response to stabilization of disease. CD4 T cells make different cytokines and chemokines, and that profile might be beneficial. We've shown that CD4 T cells that make certain chemokines also migrate to tumor sites and also recruit other effectors. I'm not going to show you that data as well, but if you can select CD4 T cells with a specific chemical profile, you may also attract other T cells and non-specific responders to the area where the tumor is. And it's a rational basis for concurrent CD4 and CD8 T cell therapy. We can grow CD8 T cells, and therefore why not give both at some point. So that was manipulating one of the intrinsic factors associated with augmenting T cell responses to tumors. The other factor is lymphodepletion, and this can be done with chemotherapy, using Cytoxin, as we did in the mouse model, or fludarabine, which decreases induces CD4 lymphopenia, or even radiation therapy. And the rationale behind doing conditioning is at least threefold. And one is to build a better environment Essentially, by giving these patients radiation or some type of lymphodepleting therapy, we reduce the lymphocyte pool in these patients. The body responds by upregulating homeostatic cytokines such as IL-15, IL-7, and other growth signals. It also removes the cytokine sink of these other lymphocytes, providing more cytokines to be available for adoptively transferred T cells. And so if you lymphodeplete these patients and then provide them with your antigen-specific T cells, hopefully these will provide increased space for transfer T cells, eliminate suppressor cells or regulatory T cells, and also apply growth factors and promote the engraftment of these T cell clones. This is obviously not something I thought of myself, but this is based upon work by many others, both in the mouse model, and this was demonstrated clinically in 2002 by Steve Rosenberg at the NCI. He used tumor-infiltrating lymphocytes, which were collected, which basically just amassed the lymphocytes of heterogeneous phenotype and specificity from a tumor site, expanded these with high doses of IL-2, 6,000 units per ml of IL-2, where we used to be between 10 and 50 units at most. And then putting these back into patients, initially didn't see a lot of significant responses that was any greater than giving high-dose IL-2. But in this case, when he lymphodepleted patients, he found that these TIL cells survived for long periods of time and induced significant tumor regression. And so the lymphodepleting regimen that he used was high-dose Cytoxan, 60 milligrams per kilogram for 2 days, combined with fludarabine, which provides a longer period of CD4 lymphopenia, and then high-dose IL-2. Now, he had to give high-dose IL-2 because this is how the T cells are grown in vitro, and high-dose IL-2 in vivo has significant toxicities, including vascular leak syndrome. Patients need to be in ICU-type setting because they drop their blood pressure, everything leaks into the lungs. Their kidneys are damaged, maybe just temporarily, but more than a quarter of the patients were intubated. The other toxicities of this trial mentioned briefly. However, first of all, he saw dramatic responses in about 50% of the patients, 3 complete responders and 15 partial responders. However, there were serious adverse events associated with this type of therapy, not only due to the high-dose IL-2, but due to complete replacement almost in some of these patients of the T cells that he infused into patients. You don't really want that. You want to prevent opportunistic infections from occurring, like PCP, and also EBV transformed lymphoproliferative diseases, which is what happens when you move the T cells and the immune response. Your B cells, which may be infected with EBV, and most of us just grow out of control in polyclonal fashion and can develop into tumors. Uveitis, which is where some of these target antigens are shared with some of the normal melanocytes or choroidal melanocytes or uveal melanocytes in the eye, and it can cause inflammation. This can be treated topically or systemically with steroids, but in one patient, he also saw cortical blindness as a result of fludarabine therapy. In spite of the dramatic clinical responses, this can only be used in patients who have accessible tumor and from whom TIL cells could be generated. And as I mentioned before, this requires high doses of IL-2. So instead of this sort of kitchen sink approach, we decided that we would eliminate fludarabine. We've actually already done a study that was published in PLOS One recently showing that fludarabine-induced lymphodepletion does increase the survival of these T cells that we give to patients. However, fludarabine is also responsible for a lot of these toxicity when used in combination with Cytoxan. Also reverses the Treg to T effector ratio, and I can talk more about that individually if somebody's interested. So we don't really like fludarabine so much. We did keep the Cytoxan because we wanted the lymphodepletion, and we didn't think we needed the high-dose IL-2 because these cells were grown with bigger cycles of stimulation in a more physiologic fashion, requiring low doses of IL-2. And so we gave 14 days of outpatient low-dose IL-2 therapy to these patients with progressive metastatic disease, and we didn't use TIL, we used antigen-specific T cell clones that could be derived from almost any patient who had the right HLA allele and tumor antigen expressed on their tumor. And so in this protocol, we evaluated safety, persistence of these T cells, and anti-tumor efficacy in patients who again had progressive metastatic disease, expressing restricting allele for this epitope. We treated 10 billion cells per meter squared. 6 patients. This is their target. These are melanocyte-associated antigens. So they will also target skin melanocytes as well as eye. Heavily pretreated with significant visceral disease sites, and the toxicities we observed were fever, neutropenia, or a skin rash. In all patients except for one, we saw a neutropenia and a skin rash developing. And this is the neutropenia that's induced in 5 out of 6 patients. This is the only patient who did not develop neutropenia. Neutropenia lasted, and the lymphopenia lasted from anywhere from 2 to 3 weeks. The arrows at the time of the T cell infusion. This is a skin rash developed on the patient. This looks like a maculopapular rash, but if you look closely, these are centered around moles and pigmented cells of the skin, and if you biopsy, you can find that these T cells have infiltrated into the dermal-epidermal space, attacking melanocytes, resulting in release of melanin, and the accumulation of melanophage, and these are CD3, CD8 T cells that were infused into patients. We could extract these, show that these are the T cell clones that we gave. So did these patients have an immune response? They obviously had a good toxicity to it. And toxicity usually goes hand in hand with efficacy, at least in immunotherapy. If we look at these two patients, one who developed neutropenia or lymphopenia, one who did not, we see that